Bismillah ar-Rahman ar-Rahim. In this session we have two talks. The first one is about how to interpret the chest X-ray, and the second one will be about the MRI of the shoulder. We'll start by the first topic about the chest X-ray, and this is just an introduction to the subject. You all know that the chest X-ray is one of the most common procedures in the radiology department, and in many departments it represents about 40% of the daily work of the radiology department. That's why this chest X-ray is very important, since it is very simple and of relatively low cost. However, it is considerably sensitive and provides some excellent resolution in the detection of pulmonary and mediastinal pathology. Then, in order to interpret the chest X-ray accurately, you should know some criteria of the optimal chest X-ray. These criteria include the patient position, the tube distance, and the ensurance of adequate inspiration, and the selection of the adequate parameters for optimal penetration of the human body. And this is the chest BA, or postero-anterior view, and this is the difference between the postero-anterior and the antero-posterior view. Actually, when the patient is facing the film, the heart is near to the film, then you will see no magnification of the cardiac shadow. But if the patient is facing the tube, this is the antero-posterior, will be the antero-posterior view, then the heart will be somewhat away from the X-ray film, then you expect some magnification of the cardiac shadow. This is the same patient, postero-anterior view and antero-posterior view. Also, the cardiac shadow will appear somewhat enlarged if the patient is radiographed while in the supine position, like those patients in the intensive care units. Then, because of the supine position of the patient is not able to get full inspiration, and also this is a frontal view, the cardiac shadow is relatively away from the X-ray film. The lateral view is obtained by putting the side of interest near to the film. Like in this case, you got left lateral view if the pathology is seen in the left lung, for example. And this is an old technique which is known as the decubitus film, and we use this technique whenever you see this finding in the chest, in the frontal chest X-ray. What is this finding? And you see the diaphragm is elevated, and the highest point of the diaphragm is a little bit shifted to the lateral chest wall. Then whenever the diaphragm is elevated and the apex is shifted laterally, you know that there is some fluid underneath the lung, what we call the subpulmonary effusion. If the patient lies on the right side, then the effusion will come into the pleural recess. But nowadays you can confirm this diagnosis simply by ultrasound. Then the optimal exposure, if you look to the chest X-ray, you can easily say that this is an overexposed film and that the pulmonary details are totally lost. And this is an underexposed film. You got haziness of the lower lung zones. You cannot see the costophrenic angle adequately. And this is the optimally exposed X-ray film, where you can see clearly the costophrenic angle, and you can also see the intervertebral discs of the dorsal spine through the cardiac shadow. Then, in order to know that the patient during exposure had full inspiration, you count the level of the diaphragm against the posterior aspect of the ribs. This is the rib number 1, 2, 3, 4, 5, 6, and the diaphragm should be at the 10th rib posteriorly. Then you are sure that the patient has got the full inspiration. Sometimes you may see the diaphragm at the level of the 11th rib, as in athletics or in emphysematous patients, as you can see. And this is an important remark in the lateral chest X-ray, where you can see the upper dorsal spine more brighter than the lower dorsal spine normally, because here the shadow of the shoulders are superimposed, and here the shadow of the lung basis is superimposed on the dorsal spine. Then if you, in the lateral view, see the opposite of this appearance, the upper dorsal vertebrae are more bright, are more darker than the lower dorsal vertebrae, then you know that there is some lesion in the lung base which is located posteriorly and superimposed on the dorsal spine. If you go to the frontal view, then you can see the site of the lesion. And how to know that the patient was positioned thoroughly during exposure? You put a landmark or a mark on the spinous process of the dorsal vertebra. Then you measure the distance between the spinous process and the medial edge of the clavicle on the left side, and then the same on the right side. These two distances should be equal. Then you know that the patient is well centralized. And if you look to this chest x-ray, you can see that there is either hypertranslucency on the right side or veiling on the left side. And there is no pathology on both sides. That this is because of the patient tilt. This is the site of the spinous process, and this is the medial edge of the clavicle on the left side and on the right side. And you can easily see that there is an increase in the distance on the right side, meaning that the patient has been tilted during exposure. And if you have the frontal chest x-ray, how can you report the site of the lesion? And you know that the lung is divided into 3 zones. The upper zone is the region opposite the first and the second ribs anteriorly. The middle zone is the region opposite the third and the fourth rib anteriorly. And the lower zone is the rest of the lung until you reach the diaphragm. This is the upper lung zone, middle lung zone, and lower lung zone. But if you have the lateral view, you can accurately locate the lesion into its lobe. On the left side, you can see the upper lobe here. This is the site of the lingula, which is part of the upper lobe. This is the lower lobe. This is the upper lobe on the right side, middle lobe, and the lower lobe. This patient had a previous cardiac surgery with sternotomy wire sutures and right-sided pleural effusion that has been extended into the fissures. Then you can see the major fissure and the minor fissure, and this is the region of the upper lobe, this is the region of the middle lobe, and this is the region of the lower lobe. Then we have to know some of the radiological signs or radiographic signs that are usually reported in the chest films. You see here what we call the silhouette sign. What do we mean by the silhouette sign? Silhouette sign means that there is an opacity in the lung which is adjacent to one of the cardiac borders. And then if you do not see the cardiac border through the opacity, then you know that this opacity is adjacent to the heart. And considering that the heart is an anterior structure, then this opacity should be anterior. And the anterior part of the lung on the right side in this location is the middle lobe, then you know that this lesion is in the middle lobe without the lateral view. Another example, if you see an opacity here, then you look to the cardiac border and you can clearly see the cardiac border through the opacity, then you know that this opacity is not anterior. It is located posterior and it is in the lower lobe, not in the middle lobe. Then if I asked you about the position of this opacity, do you think that this is anterior or posterior? Posterior. Then look at the CT scan and then the opacity is actually posterior. It is a mnemonic consolidation in the left lower lobe. Then you came to the second very important sign, which is the air bronchogram. Air bronchogram means air in a patent bronchi on the background of consolidated lung. The alveoli are opaque due to the presence of some secretions, but the bronchi are patent, containing air. Then if you see this air bronchogram, you are sure that this lesion is of pulmonary parenchymal origin. And this lesion also is of alveolar nature. And this lesion also is a consolidation. Then the mere presence of air bronchogram can tell you three important facts about this lesion. It is pulmonary, it is alveolar, it is consolidation. Then some of the terminologies commonly used in the reports, and the first one is the pulmonary nodule. What do we mean by a pulmonary nodule? The nodule is a well-defined lesion that is less than 3 cm in diameter. The pulmonary mass is a well-defined lesion that is more than 3 cm in diameter. The pulmonary patch is an ill-defined lesion containing air bronchogram. The pulmonary cavity is a well-defined lesion containing air. Either this air is total or partial with some fluid inside this lesion. Then, how to interpret the chest X-ray considering the previously mentioned facts? Number one, you should ensure that the X-rays are of optimal quality. Then you should have a good hint about the patient data and the clinical condition. And if you are able to obtain the previous film, or if there are previous films, this will be of great benefit in the diagnosis. Then starting the evaluation, you should discriminate between these two conditions. The first one is known as the focal lung pathology, where you see a pulmonary lesion, 1 or 2 or 3, but the rest of the lung is clear. Then if you look to this chest X-ray, you can see diffuse pulmonary parenchymal disease, which affects both lung fields. Then if we select the first option, where we will deal with focal lung lesions, then the focal lung lesions are only 4. Either you are dealing with a nodule, or a mass, or a patch, or a cavity. And these are the nodules or the lesions. The focal lesions can be seen in this chest X-ray. Then we'll start first by the pulmonary nodules. And the pulmonary nodules, by definition, is a well-defined lesion that is less than 3 cm in diameter. Actually, there are many pulmonary nodules can be confronted in the chest X-ray, but we used to be concerned about the most common pulmonary nodules met in the clinical practice. I suggest that the pulmonary nodules that can be confronted in the clinical practice frequently are 6, and they include the tuberculoma, the hamartoma, the bronchogenic carcinoma, metastasis, arteriovenous malformation, and the hydatid cyst. Then I can ask you if you know another pulmonary nodule which is seen in the lung other than these 6 possibilities, considering only one factor, which is this pulmonary nodule you mentioned is seen at least once per year. That's to say, it may be seen during your practice. If it is seen once per year, then we can include in this list, and we try to differentiate it from others. Can anyone suggest a nodule that is seen at least once per year other than these 6? Try. No? Very good. If you cannot, this is a solid rule and a very good in the clinical practice. If you see a pulmonary nodule in the lung, it is most likely one of these 6 nodules. Then we started the differential diagnosis. These pulmonary nodules, the most easy one of them is the metastasis, because metastases are usually multiple. Then what do you think about solitary pulmonary metastatic deposit? Is this a possibility or not? Yes, it is a possibility. And sometimes you got a pulmonary nodule which is a metastatic deposit, and at that time you cannot diagnose metastasis unless you know that the patient had a primary malignancy. Then if the metastases are multiple, the diagnosis is easy even without the clinical history. But if the deposit is only solitary, then you should know about the clinical history of the patient. Then look at this CT scan with numerous pulmonary nodules and pleural effusion. The diagnosis is easy even in absence of a known primary malignancy. These are representing metastatic deposits. Another case of metastatic deposits from a known breast cancer showing masses and nodules as well. We'll discuss this in a moment. Then, if you see a pulmonary nodule with a smooth margin containing calcium, the smooth margin and the calcification are usually indicative of a benign lesion. Then the most common lesions presenting in this way are the tuberculoma and the hamartoma. What is the difference between tuberculoma and hamartoma? Tuberculoma occurs in the apices of the lung, hamartoma occurs anywhere. Tuberculoma shows calcium by any appearance, hamartoma shows calcium in the form of popcorn appearance. But usually we do not try to differentiate between both, but sometimes you can easily reach the diagnosis. Here you can see a pulmonary nodule which is totally calcified, and lymph nodes in the mediastinum which are also calcified. Then it is easy to know from the position of the nodule and the total calcification and the presence of calcium in the lymph nodes that this is a tuberculoma. Then, if you look to this chest X-ray and you see fibronodular infiltrations in the apex of the right lung, you know that this is tuberculous infiltration, then this nodule should be tuberculoma in the course of the disease. If you look to this nodule, which has a smooth margin with calcifications inside the nodule, then you may suspect tuberculoma or hamartoma. But because of the location of the lesion and the shape of the calcium, you are mostly diagnosing a pulmonary hamartoma. Then this is a smooth margin of a nodule with central calcification suggestive of a benign lesion, either tuberculoma or hamartoma. And this is a smooth margin with central calcification showing the same or indicating the same diagnosis. Then we usually discriminate between tuberculoma and hamartoma by the history, by the presence of other changes in the lung, and by the location of the lesion in cases of tuberculoma. Then if you see a nodule with a speculated margin, and this is the speculated margin which indicates that this is a malignant lesion. Speculation is due to the spread of the tumor invading the adjacent lung parenchyma. Then if you can see this, you are diagnosing a bronchogenic carcinoma. Then this is the nodule in the right lung base, and you can see the speculated margin in the lung window of this CT scan, diagnostic of bronchogenic carcinoma. And this is also the classic appearance of bronchogenic carcinoma with a speculated margin by CT. Then if you see a nodule with water density, you know that this is hydatid cyst. And I have stated yesterday that the only nodule or mass filled with water in the lung is pulmonary, is hydatid cyst. There is no differential diagnosis for this lesion. The lesion which is containing water in the lung should represent a hydatid cyst. And you remember that calcium in the pulmonary hydatid cyst is extremely rare, does not occur in the clinical practice. Then you may ask yourself about the lung abscess. What is the appearance of the lung abscess against the hydatid cyst? The abscess in most of the cases should contain air, then it will represent a cavitary lesion as we will discuss later on. But suppose this abscess is totally filled with pus, then the wall of the abscess can discriminate the abscess from the hydatid cyst, where the abscess has a very thick margin which enhances with contrast material, while the hydatid cyst has a very thin margin which does not enhance with a contrast material. Then a nodule or a mass in the lung filled with water or fluid density, this represents hydatid cyst. Then one of you may ask about the insisted effusion in the fissure. And the encysted effusion is not a nodule or a mass. It is elliptical in shape. Number two, encysted effusion is not in the lung. Encysted effusion is in the fissure. Then you can easily discriminate between the hydatid cyst and these two entities. Then we came to the pulmonary vascular malformation, and the pulmonary vascular malformation is a nodule that is connected to the hilum by two cords. The first one is the feeding artery, and the second one is the draining vein. Then if you see these two connections to the hilum, you know that this is a pulmonary vascular malformation. And sometimes you can see only one cord connecting the nodule to the hilum, and this is enough for diagnosis because the second cord may be behind the first one or will appear in another section by CT scan. Then when we suspect a pulmonary vascular malformation on the basis of these chest X-ray finding, the pulmonary nodule connected to the hilum by two cord-like structures. Previously, before the era of multi-detector CT, we used to introduce a catheter in the pulmonary artery and we inject the contrast material. Then you can see the feeding artery, the AVM, and the draining vein. But nowadays, if we suspect the possibility of a pulmonary vascular malformation, we can use the multi-detector CT, injecting few milliliters of contrast material intravenously. Then we scan the chest. Then we can see the feeding artery and the draining vein and the pulmonary vascular malformation. Then what happens if you look to the chest X-ray and you see a nodule like this? Then you have to answer 4 questions. Number 1, what about the edge? Is it smooth or speculated? What about the presence of calcium? Is calcium here is present or not? What about the density? Is this a fluid density or a solid density? What about the vascular pedicle? Is this nodule has a vascular connection to the hilum or not? If you fail to answer any one of these questions, the second step should be CT scan. If you fail, and you will fail, of course, because the chest X-ray will not lead you to suspect that this is fluid. You should have a CT or ultrasound to confirm the possibility of fluid. Then if you do a CT scan, then you can see that this nodule has a speculated margin and it is a neoplasm, not a benign nodule. Then we have 6 common pulmonary nodules. Tuberculoma and hamartoma has a smooth margin and calcium inside. Bronchogenic carcinoma has a speculated margin. Hydatid cyst contains water density. AVM has a vascular pedicle. Metastases are multiple, or the patient had a history of primary malignancy. Then we came to the masses. The masses are only 3. The bronchogenic carcinoma, which is large. The hydatid cyst, which is large. The metastatic deposit, which is large. Then I ask you the same question. Do you know a mass in the lung that is seen in the clinical practice at least once per year other than these 3 possibilities? Yes, this is the cavitary lesions we'll discuss later on. Do you know? Sorry? Wagner's granuloma. Wagner's. Yeah. Wagner's granulomatosis, in fact, they are presented in as a pulmonary nodules which usually cavitate, and they contain central air and so. Then, let us say the frequency of Wagner's in the clinical practice. Is it seen once per year? No? Okay, very good. And any other possibility? No? Okay. Then this is a more solid rule. Whenever you are confronted by a mass in the lung, there are only 3 possibilities. Either this mass is a bronchogenic carcinoma, or hydatid cyst, or metastatic deposit. Then how can you differentiate these 3 from each other? The hydatid cyst contains water. Then if you do a CT scan and you see water inside this lesion, this is a hydatid cyst. And the metastasis should have should be multiple, or the patient had a primary malignancy. Then we are left with bronchogenic carcinoma. And here is the second rule in the chest X-ray. Any mass in the lung in an adult should be considered as bronchogenic carcinoma until proved otherwise. Then if you look to this mass in the lung base after CT, it contains water, then you are dealing with hydatid cyst. Then look at this mass in the left lung, and you can easily suspect the position of this mass. Is it anterior or posterior? Yes, posterior. Then you see the mass containing water, then you are dealing with hydatid cyst. Okay, this is the mass when a CT scan showed solid nature, but it showed calcium inside the mass. Then calcium in the mass is of no diagnostic value. Calcium in the mass you can ignore totally. It does not mean a benign lesion. Calcium in the nodule is very important, but calcium in the mass is of no significance. Then if you see a mass in the lung in an adult containing calcium or not, showing a smooth margin or irregular margin, this should be a bronchogenic carcinoma until proved otherwise. Okay, if you see a mass in the lung and the patient is known to have a primary malignancy, then you are dealing with metastasis. This is a 14-year-old male with osteosarcoma. Then this is a huge metastatic deposit from osteosarcoma. Then what do you think about this case? There is a mass in the lung on the right side. The diaphragm is markedly elevated due to phrenic nerve paralysis. Without elevation of the diaphragm, any mass in the lung in an adult, it represents a bronchogenic carcinoma. Then look at this mass also. There is a mass in the apex of the left lung. By CT, you see the solid nature of the lesion and the presence of calcium. Then you are dealing with bronchogenic carcinoma. Then what do you think about this lesion? There is a mass in the apex of the right lung. Then we should have a CT scan in order to exclude that this mass contains water. Then this was a solid mass, and the diagnosis is a bronchogenic carcinoma. Then if you see multiple masses like this, the diagnosis is easy, metastatic deposits. If they are mixed masses and nodules, they are deposits. If they are nodules only, they are deposits. Masses only, they are deposits. Multiple masses or nodules or masses and nodules should represent metastatic deposits until proved otherwise. This patient had a cancer breast. He is a male and with a cancer breast, and you can see multiple lesions in the right lung representing metastatic deposits. Then, if you see multiple lesions in the lung and you want to differentiate between deposits and hydatid cyst, what do? You do a CT scan. If the lesions contain water, then they represent hydatid cysts. If the lesions are solid, then they will represent pulmonary metastasis. And this is an example of pulmonary metastasis of mesothelioma. Then look at these two masses. These two masses may be either metastasis or hydatid cysts. Then what to do? Just to do a CT scan. Then you see fluid density inside the lesion. Then you are dealing with hydatid cysts. Then you have three masses in the lung, two solid and one cystic. The two solid lesions are metastasis and the bronchogenic carcinoma. The cystic lesion is the hydatid cyst. Then we come to the patches. The patch is an ill-defined lesion with air bronchogram inside. And by this air bronchogram, you know that this is a pulmonary lesion, alveolar pathology, and it is consolidation. There are only two which present like this, which are the pneumonia and the infarction. Then if I asked you about the frequency of pneumonia against the frequency of infarction, which is more common? Yeah, of course. Then we used to diagnose any patch in the lung as pneumonia unless we have a clear history of infarction. Then if I see a lesion like this with an air bronchogram, pleural effusion, then this is pneumonic consolidation. There are a lot of lesions which can produce alveolar filling or consolidation, as we can see. These If you remove the air in the alveoli and put fluid, then you got pulmonary alveolar edema. If you remove air and you put exudate, then you have pneumonia. If you remove air and put blood, this is pulmonary hemorrhagic disorders. If you remove air and put tumor cells, this is alveolar cell carcinoma. If you remove air and put proteins, this is alveolar proteinosis. But all these lesions occur in a diffuse pattern. Pulmonary edema, pulmonary hemorrhage, pulmonary alveolar cell carcinoma, alveolar proteinosis, except pneumonia, which can occur in a diffuse pattern and also in a focal pattern. Since we are dealing with focal lung lesions, we will diagnose pneumonia against the infarction whenever you see an area of consolidation with air bronchogram inside. If you have adequate history of fever, cough, and expectoration, then you are dealing with pneumonia. If you don't have any history, you are dealing with pneumonia until proved otherwise. Then this is the pneumonia in a male patient, 38 years old, with fever and expectoration. You got some veiling in the right lower lung zone. By CT, you can see consolidation with air bronchogram. After treatment with follow-up, and you get clearance of the lesion. Another case of pneumonia in the right lung, and the pneumonia is projected in the lower lobe in the lateral view. Then, if you look to this opacity, which is like a triangle with the base outside, the apex inside, in the lung base, these are not the criteria of an infarction. And we do not usually diagnose pulmonary infarction based on the previously mentioned criteria. We diagnose pulmonary infarction based on the history. If the patient has acute chest pain and hemoptysis, especially if he is complaining of deep vein thrombosis in the lower limbs, then you got the full-blown picture of pulmonary embolism. But if you don't have the history, and in the CT scan you see this appearance, which is an embolus in the pulmonary artery, and you can see also the pleural effusion, then you know that the lesion you are dealing with is an infarction. Look at this male patient, 43 years old, with acute chest pain and hemoptysis. The mediastinal window, you can see the embolus. In the lung window, you can see 3 infarctions, which appear as patchy areas in the lung, 2 in the lingula and 1 in the posterior segment of the lower lobe with pleural effusion. Then we came to the fourth type of the pulmonary focal lesions, which is the cavities. And cavity by definition should contain air. And air only, like this cavity, air and the fluid, like this cavity, and air and the mass, like this cavity. Then air is an important finding in the lesion to diagnose a cavity. Then we go in the differential diagnosis. We start first by the cavity which contains air only. Then we look at the wall. If the wall is thick, we have 2 possibilities. If the wall is thin, we have 2 possibilities. Then start by a thick-walled cavitary lesion, and the wall is thick. Then you have 2 possibilities. The first one is the chronic lung abscess. The abscess starts by a small amount of air and a big amount of pus. And by time, pus is expectorated and you are left with a cavity filled with air. This is the chronic abscess. And the second possibility is what we call the breakdown in a neoplasm. The bronchogenic carcinoma may have a central area of breakdown with tumor shreds. Then the tumor shreds are expectorated and you are left with a cavity with thick margin and containing air. What is the difference between the chronic lung abscess and the breakdown in a tumor is the inner wall of the lesion. The inner wall of the lesion is smooth in the case of an abscess. The inner wall of the lesion is irregular in the case of the tumor. Then if you see a cavity with thick margin containing air, the differential diagnosis is between the chronic lung abscess and the breakdown in a bronchogenic carcinoma. If the inner margin of the lesion is irregular, you are dealing with bronchogenic carcinoma breaking down. If it is smooth, you are dealing with an abscess. This is a lung abscess, and you can see the smooth inner margin, and there is still some air fluid level inside the abscess. This is the sequence of the abscess in the lung. Acute abscess will contain minute amount of air and a lot amount of pus. Then the air will increase and the pus will decrease until you are left with a cavity totally filled with air, while the inner margin of the cavity is smooth. Then you know that this is a chronic lung abscess. Then if you see a cavity with air and the wall is thin, there are two possibilities. The first one is an hematocele, and the second one is an emphysematous body. To differentiate both from each other, hematocele is usually located within the lung, while the emphysematous body are usually located at the periphery of the lung, subpleural in location. Then what about the cavity containing air fluid level? There are two possibilities. The first one is the usual abscess, an air fluid level in an abscess. And the second one is acute rupture of the hydatid cyst. If the hydatid cyst is ruptured, you will get an air fluid level. And the daughter cysts inside this hydatid will float on the surface. Then you will get what is known as the water lily sign. And in cases of ruptured hydatid cyst, the surface is wavy, while in cases of acute abscess, the surface is straight. Okay? Then we are left with the last issue, which is a cavity with a mass inside the cavity. A cavity with a mass inside, the first possibility and the most common possibility is a fungus ball within a chronic lung cavity, like a tuberculous cavity, for example. Then if you see a cavity with a mass inside, first possibility at all is the fungal ball Mycetoma aspergillum. Then if you look to this cavity, what do you think about this cavity? This is a thick wall cavity containing air, and the wall is irregular. Then you are dealing with a neoplasm. Okay, what happens if you see a ball inside the cavity? Does this change the diagnosis? No. A cavity with a ball inside or a cavity without a ball inside showing malignant criteria, which are thick margin and irregular inner wall. Then another possibility of a cavity with a mass inside is necrotic tumor. But the necrotic tumor is originally diagnosed throughout the major criteria, which are the thick margin and the irregular inner wall. Then we finish with the interpretation, and it came your part in answering the questions. Okay. In order to interpret the chest X-ray, we are dealing, all these questions deals with the focal lung lesions. Then you should specify first which category you are dealing with, nodule, mass, patch, cavity. Then if you are dealing with nodules, and they try to select one of 6. If you are dealing with masses, you are to select one of 3. If you are dealing with patches, you try to select one of 2. If you are dealing with cavities, you try to select one of 8. These are the whole focal lung lesions. Then, are you dealing with nodule, mass, patch, cavity? Nodule. What do you think about? AVM. Why AVM? Because the nodule is connected to the hilum by a vascular pedicle. This vascular pedicle may be double or single. It does not differ. Okay? Then, what do you think? Mass. You can reach the diagnosis, or you need further evaluation? Yes, you need CT to know if this mass contains water or not. If it contains water, it will represent hydatid cyst. If not, it will be a bronchogenic carcinoma. This patient did not perform a CT, but performed a follow-up after 1 day. And this is the follow-up. Yes, ruptured hydatid cyst. This was a hydatid cyst and ruptured with a wavy air fluid level. Okay. Nodule, mass, patch, cavity? Cavity. Thin wall, thick wall? Thin wall. Peripheral, central? Diagnosis? Emphysema. Very good. Nodule mass batch cavity. Mycetoma. Very good. This is a cavity with a mass inside the cavity. This is mycetoma even without the need for CT scan. Mycetoma, aspergilloma, fungal ball, or the same. Batch. Batch without history is pneumonia. Batch without history is pneumonia. Dual mass batch cavity. Cavity, lung abscess. Very good. Okay. Dual mass batch cavity. Mass. CT. Hydatid cyst. Dual mass batch cavity. Nodule mass. What is the diagnosis? Sorry? Solid. Yeah, you want CT or you can reach the diagnosis. It looks benign with a smooth margin in the apex of the lung. It may represent tuberculosis. Can you do this diagnosis? No, I don't advise you to do so. This is the CT scan of the lesion. It is? Yes, it is a bronchogenic carcinoma. Never do that. If you are not sure about the 4 questions, do CT. If you are not sure, do CT. Don't leave the patient. Okay. Huh? Nodules. Nodules, many nodules, and a patient with carcinoma of the colon, then you know that these are metastatic deposits. Okay. Very good. Elevation of the diaphragm with shifting of the apex of the diaphragm laterally, then you are dealing with subpulmonary effusion. Nodule mass batch cavity, batch. The diagnosis without history is pneumonia. Okay. Nodule mass batch cavity, malrotation. Very good. And you see it, malrotation, which has resulted in this appearance. Nodule mass batch cavity, cavity. Diagnosis, fungal ball, aspergilloma, mycetoma. Nodule mass batch cavity, nodule, totally calcified tuberculoma. Okay. Nodule mass batch cavity, cavity. Okay, cavity with fluid level may represent an abscess. But this wall of the lesion, is it thick or thin? Thick. And what about the inner margin? It is regular or irregular? Then, and the breakdown of a neoplasm, you may get a fluid level, which represents the necrotic material inside the lesion, and you may get a ball, and you may get both a ball and a fluid level. Then the most important of this, I emphasize this once more, is the thickness of the wall and the irregularity of the inner margin. Don't look to the air fluid level or the mass inside the cavity. This is a cavitating bronchogenic carcinoma. Nodule mass batch cavity, mass. CT, bronchogenic carcinoma with pleural effusion in KC. Okay. Dual mass batch cavity, batch. Which side? Right side. Okay, what do you think? Mnemonic consolidation, yes? Where is it in the lateral view? Sorry? Fissure? Not seen in the lateral view, yes? Collapsed. If it is collapsed, you get traces of the collapsed lung. Sorry? Ool. Huh? Yes, this is the breast shadow. Very good. Why is the breast shadow is not symmetric? Because the patient is not symmetric. Yes, okay, very good. Nodule mass batch cavity? Abscess? Yes, and you see the wavy appearance of the fluid level. This is the rupture, the hydatid cyst. Nodule mass batch cavity? Batch. The diagnosis is pneumonia. Nodule mass batch cavity? Cavity? Thick wall? Chronic abscess or neoplasm? Neoplasm, because of the irregular margin of the tumor and the metastatic lymph node posterior to the superior linear. Nodule mass batch cavity. Cavity. The diagnosis is lung abscess. Okay. Nodule mass batch cavity. Cavity. No. Thin wall, thick wall. Thin wall. Nematocele. Very good. Nodule mass batch cavity. Nodule mass. Nodule or mass, it will not differ. The diagnosis is hydatid cyst because of the water density. Okay. Do you see the lesion? Nodule mass batch cavity. Where? On the left side here. Right upper. Here. Yeah. Yes. This is the lesion. Nodule mass batch cavity. Batch. This is pneumonia and we let the patient go home. No. Okay. CT. Yes, it is a bronchogenic carcinoma with a speculated margin. Okay. Nodule mass batch cavity. Cavity with fluid level. The diagnosis is abscess. This patient is a male patient, 67 years old, presented by brain metastasis. Then we have a procedure when you are confronted by a patient with brain metastasis, look to the primary in the chest. Always do this. Then the chest X-ray showed the pulmonary nodule in this area, and the CT scan showed this configuration, which was biopsied and proved to be bronchogenic carcinoma with a speculated margin. Nodule mass batch cavity. Nodule. The diagnosis is metastasis. This one? This one? Okay, this is metastasis, solitary pulmonary metastasis. Very good. This is symmetric pulmonary basal nodules which represent nipple shadows. Okay. Nodule mass batch cavity. Mass. What do you think? CT. Okay. This is the 15 years old child with Ewing sarcoma. Metastasis. Nodule mass batch cavity. Nodule mass batch cavity. Mass. التشخيص nodule. AVM. This is the nodule which is connected to the hilum by a vascular pedicle. This is the TC scan showing enhancement similar to the aorta, diagnostic of a vascular malformation. Subpulmonary effusion because the diaphragm is elevated and the apex is shifted laterally. Bronchogenic carcinoma with a speculated margin. Necrotic tumor. Cavity air fluid level. If you do CT for every patient, you will. Do you feel that this wall is very thick and irregular from inside? I don't feel that this is a lung abscess. Okay. Nodule mass batch cavity. Where? Okay, this one. What do you think? CT? Okay, CT. Tuberculum. Hamartome. Yes, this was a hamartome. Yes, what do you think? Emphysematous bully. Multiple thin wall cavitary lesions filled with air in the periphery of the lung. Nodule mass batch cavity. Cavity. Chronic abscess. Very good. Nodule mass batch cavity. Cavity. Tumor. Yes, this cavity has a thick margin with a nodule inside and the air fluid level, and this was the CT scan, and this has been proved to be squamous cell carcinoma cavitating. Nodule mass batch cavity, mass, CT, containing calcium. No, calcium is not of significance in the masses. This is bronchogenic carcinoma. Okay, nodule mass batch cavity, mass, CT, bronchogenic carcinoma. Okay, nodule mass batch cavity, mass, CT, bronchogenic carcinoma. Okay, nodule mass batch cavity, nodule, CT, أهو tuberculoma, calcified nodule tuberculoma. Okay, nodule mass batch cavity, batch, mnemonic consolidation. Look carefully in this this apically located opacities. You should look carefully to the ribs, and you can see here that the first rib is destroyed, the second rib is also destroyed. Yes, this is Bankos tumor. This is if you see a consolidation in the lung apex. يا جماعة اللي ورا بتتكلموا مع بعض الله يخليكم عشان لو سمحت باقي دقيقتين ونخلص بعدين نتكلموا زي ما انتوا عايزين. Nodule mass batch cavity, mass, nodule. Diagnosis is bronchogenic carcinoma, and this is the CT scan. Confirmed the speculated margin, which is clearly seen in the plain film. This was an asymptomatic patient with a bronchogenic carcinoma. Nodule mass batch cavity, nodule. CT or you reach the diagnosis. Okay, this is a CT. Nodule mass batch bronchogenic carcinoma. Okay. طيب. Nodule mass batch cavity. Okay, lung abscess. Metastasis, very good. Are you sure that there is water inside? You should have the mediastinal window. Then the wall is very smooth and the density is that of water. Then you are dealing with hydatid cyst. And thank you very much.